Hi, I'm Dr. Amy Serin, neuropsychologist and EMDRIA-trained EMDR therapist. And we've had an amazing response with touch points from EMDR-trained therapists who want to know more about the justification of using bilateral alternating stimulation in the tactile form, that's our BLAST technology, during phases 1, 2, and 3 of your 8-phase EMDR therapy protocols. Many of you are also concerned with dissociation, so I'm going to address that today. So today we're going to cover EMDR therapy phases 1, 2, and 3 using Touchpoints Original, and I'm going to go through some of the research that justifies this practice. Your brain is always after homeostasis or balance, and the autonomic nervous system has the word auto in it because that implies that it's doing something without you thinking about it. And this is why when people try to think their stress away or do something conscious to get their stress to go away, it often fails. Stress is a decision that our brain makes for us without our awareness. And your brain is constantly deciding whether or not to be in parasympathetic activation, and that's your rest and digest nervous system where you're calm and focused, or your sympathetic nervous system. This is your fight or flight sympathetic nervous system where stressful activity dominates. And when you're in sympathetic arousal, nothing great is happening. We're only supposed to be in that state when we're literally being chased by a saber-toothed tiger or a snake. And unfortunately, many of us live too often in this nervous system. This wreaks havoc on our health, it wreaks havoc on our relationships, our daily functioning, and our sleep. Contrary to popular belief, EMDR therapy is not just moving your eyes or getting some kind of alternating stimulation. It's actually an 8-phase comprehensive psychotherapy treatment that was originally designed to alleviate traumatic distress, although now it's being used for a variety of different conditions. Francine Shapiro developed the adaptive information processing model, which posits that EMDR facilitates the accessing and processing of traumatic memories and adverse life experiences, and this results in adaptive solution. Distress is relieved, negative schemas about yourself can be changed, and physiological arousal is reduced and eliminated. Now, if you look at those two things, this is a very, very important model because accessing traumatic memories is the first step. And so anything that actually promotes memory and enhancement or retrieval is theoretically going to be a benefit as used in EMDR therapy. Additionally, physiological arousal is a very, very important thing to reduce because if you're cognitively upset about something, you will actually have physiological arousal. And many times we think we want to relieve the cognitive distress first. We want to rationalize something and think, I know I don't need to be upset about this right now. However, our nervous systems are telling us a different story. If we cognitively can rationalize something, but our heart rate is racing, then our body is actually not in alignment. So what I like to do is think about how we can reduce the physiological distress first, and then the cognitive distress will follow. And this is why using BLAST technology in phases 1, 2, and 3 is so important because we can actually take the 8 phases of EMDR therapy and use them with fidelity, but we can shorten the amount of time it takes to process those and resolve the physiological arousal. Now, Shapiro's hypothesis goes on to say that EMDR facilitates the traumatic memory network access. It enhances the information processing and can create new associations that are forged, and these result in complete information processing, learning, emotional distress elimination, and cognitive insight development. So in theory, we can take any traumatic event and get to the point where thinking about that traumatic event does not produce physiological arousal, does not kick somebody into sympathetic activation. So I can think about a fight I had with my spouse, for example, and my heart won't race, I won't feel badly about my behavior, and I'll be able to use that as a learning experience and move on in my life. There's a 3-pronged approach to EMDR, and this is very important. First of all, past events contributing to dysfunction need to be processed, and new associative links with adaptive information are created. So if I feel very guilty about something that I've done, and I process that, my guilt resolves, I learn from that, and I'm then better the next time. And what's wonderful about this 3-pronged approach is that spontaneous behavioral change is actually what we're after. Too many models of psychological change have people really trying hard to change their behavior, but there are oftentimes barriers to that change. And with EMDR, once you process a target, that spontaneous behavioral change occurs. So for example, if somebody's on a diet and they can't seem to stop eating unhealthy foods, we say try to control it, try to structure it, do all of these things behaviorally. But if you actually go in and process your feelings about yourself and all the distress that you've associated in your life with being a weight that isn't ideal, then you'll actually be more likely to just go ahead and eat healthy. Additionally, you can use blast technology in real time to reduce cravings, because when your physiological arousal is not to the point where you're in sympathetic activation, you can make a better choice. The second part of the three-pronged approach is that current distress triggers are targeted and internal and external triggers are desensitized. And the third part is imagine future events are incorporated to build adaptive functioning skills. We all have our desired selves, and how we want to be differs than how we are right now in that moment. There is a bridge to that person that we want to become, and the bridge is EMDR processing. The advantages of EMDR therapy is that verbalization of details is unnecessary. This is a very, very important paradigm shift in the way that we handle therapy. People think that we need to talk, gain insight, write about things, and it's simply not true. I've gone through entire protocols with my patients where they did not tell me what happened, because if they were so ashamed of their behavior or of things that happened to them that they would not have engaged in therapy if they needed to talk about it. I had them verbalize different things, but they didn't tell me what happened until their shame was resolved, and then they were actually able to talk about it without distress. EMDR therapy typically has no homework, although what I do with my patients is I have them take touch points, and after I've screened for dissociation and I've ruled that out, I allow them to take the touch points home and actually use them safely, not to process the trauma without me, but to actually desensitize their nervous system response in real time. But other than that, EMDR therapy does not require homework. What we have also, as I've discussed, is spontaneous behavioral change. The behaviors that you want will change spontaneously. So for those of you who do feeling state addiction protocols, for example, you have somebody who is overindulging in alcohol or may even be an alcoholic who has tried over and over to control or stop their drinking. Once you engage in the feeling state addiction protocol with them, they actually don't want alcohol, and it's much, much easier for that behavioral change to emerge in a positive direction. Children doing EMDR process incredibly quickly. I can typically get through 3 or 4 targets with a 4 or 5-year-old in just one session. Some of the research shows that there's a better dropout rate, and complete resolution of distress is possible. When you're evaluating research and deciding what modality to use, please keep in mind that the resolution in some cognitive therapies and other therapies is not the same as the resolution in EMDR therapies. And faster resolution of panic, anxiety, and distress. There is research that supports that for people who have gone through single incident post-traumatic stress disorder, they can get full resolution of the PTSD in fewer than 6 hours of treatment. And I really encourage you, if you're an EMDR therapist, to watch this, to spread the word about what's possible, because the population at large tends to think that PTSD is a life sentence, and all of the therapists that are doing EMDR know that that's simply not true. Now I'm going to talk about using Touchpoints Original in the therapeutic context and go through the research that supports the use of bilateral alternating stimulation in the tactile form in phases 1, 2, and 3. Now there are 2 kinds of touch points, originals and basic. Therapists typically will use the originals because they're controlled by an app. So you essentially have a remote control, which is your smartphone or a tablet, and you can control from across the room the on and off of the touch points while your patients use them. For your patients use at home, they can use either the original or the basics, and there's information on the website as to how to determine which would be the best product for them. But it's the same technology in both products. Okay, so we're going to talk about phase 1 now, history and treatment planning. The very first thing you always do is screen for dissociation. Thank you, Dr. Sandra Paulson, for enlightening me and educating me on this. And many of you EMDR therapists are very concerned about the use of the touchpoints technology outside of the office for fear of dissociation. If you are following EMDR guidelines and protocol, you've already screened for dissociation before you use bilateral alternating stimulation in the tactile form. So let's be very clear. In phase 1, you only use bilateral alternating stimulation in tactile form with the touch points or another or tapping or whatever you're doing, and I'll discuss why tapping isn't ideal later. But you only do this after you've screened for dissociation. And there are several screeners out there. The first is the MID, and this is Paul Dell's Multidimensional Inventory of Dissociation. There's going to be a link on the presentation here for you. There's the DES-2 screener, the SDQ-20 and the SDQ-5. Those are the somatoform dissociation questionnaires. And then the DDIS by Colin Ross, and that's particularly for inpatient use. So be careful when you're screening using that in an outpatient setting. Okay, so the very first thing is to screen for dissociation. And once you've determined that someone is not dissociative, then you start your history and develop your treatment plan. And what I typically do in this history is someone who does not have DID comes in, okay, I've screened them, and we start talking. They're immediately in distress. And if you don't believe me, start asking your patients about the body sensation immediately. What are you feeling in your body right now? They will tell you that they're distressed. They are sympathetically activated when they come in and they sit on your couch or your chair for the first time. If you introduce the touch points at that point, here's what can happen. Let's say your patient comes in and they say, well, I'm here because I'm having some marital difficulties or difficulties with my children. What I typically do is say, I have these devices, they're non-invasive, and they're just a gentle vibration back and forth. I'm going to hand these to you, if that's all right with you, and turn them on. And if you don't like them at any point, you can tell me. But this may take the edge off some of the stress, because I recognize that it takes a lot of courage to be here today. And it's a stressful situation to come in and to talk to somebody new about the distress in your life and everything that you've been through. Then you activate the Touchpoints Original with your cell phone. And if you'd like, if they're sensory sensitive, you can adjust the settings. You can usually start on the calm setting, okay? And normally what your patients will tell you is, wow, this feels much better. And what you're doing is you're actually, some people would say you're introducing exposure with response prevention at that point and not just exposure, okay? Because the response prevention piece would be that you've got the blast technology actively lowering the nervous system response, okay? And you're actually resolving the body sensation. If they had a body sensation of 7 when they walked in, they should report fairly quickly that that body sensation goes down to about a 2 or 3. And our statistics from over 1,000 actual consumers show that the distressing body sensations will be cut by over 50% in about 30 seconds. And you know from adaptive information processing model that as soon as you get a physiological de-escalation, then the cognitive appraisal can change. So if you start someone out with a subjective unit distress of a 7 and a body sensation of a 6, and you wait till phase 4 without using touch points, you're starting at those same levels. But if you use touch points in the history taking, you can generally resolve the body sensation before phase 4. And then what will happen is you will actually have a shorter phase 4, and they won't be as distressed as they're waiting for you to begin phase 4. Okay, so when you're developing the treatment plan and defining the EMDR targets, you actually can use touch points in phase 1. And now I'm going to show you the justification for that. As a neuropsychologist, I don't like to do anything that I don't have research on, and I know that you all are very, very concerned as EMDR therapists as to not doing any harm to your patients, and you did not get into this field because you were careless individuals. You're very thoughtful about what you do, and you care deeply about the people that you treat. So let me help you out with this. Nieuwenhuis, I think I'm pronouncing that correctly, and others in brain and cognition found that there's a significant benefit of normal memory retrieval with the eye movements and the bilateral alternating stimulation, but not auditory, okay? So the first thing I want to be clear about is that I don't talk about auditory stimulation. Music therapy is wonderful. Definitely auditory has an effect on our arousal system. However, doing alternating auditory stimulation does not seem to have the same benefit as the tactile stimulation and the eye movements. I'm also differentiating between the eye movements and the tactile stimulation because they are not the same. And I'm going to say that over and over again. And if you watch more of my stuff, you're going to get sick of me saying it. They are not the same. Do not sit your patient down in your session and ask them what they would prefer, auditory, tactile, or eye movements. They are not the same thing. And when I do more trainings on phase 4, I will tell you over and over again, during phase 4, you want the eye movements alone, or I actually prefer the eye movements with tactile stimulation, and then auditory, if you want to throw it in, go ahead. But when your patients have a reaction to the eye movements, that is probably a somatosensory reaction that can be worked through, unless it's specific situations. So don't be really gun shy and cut them off of the eye movements, okay? So eye movements and tactile stim, but not auditory stim, enhanced memory retrieval. So why is this good in phase 1? It's good in phase 1 because remember back to AIP, adaptive information processing. When you improve memory retrieval, okay, you're more likely to be able to process something to adaptive resolution. And you don't want to do the eye movements though in phase 1. And why don't you want to do the eye movements? Well, number one, you can't multitask with eye movements, okay? Eye movements are really that dual attention stimuli. They have to be doing eye movements and thinking, and then you stop them. Tactile stimulation or the blast technology, you can just have that on while you're discussing something with somebody. They don't have to stop their process or their flow in order to be benefiting from physiological de-escalation with that on. So I'm not asking you in phase 1, and let's be clear here too, I'm not saying to put the tactile stim on and then have them stop and tell you what they notice. That's phase 4 stuff. The phase 1 use of this is just having it going on continuously while you're talking. And in some rare cases, you'll have a patient that gets annoyed by it after a few minutes. Once their arousal is de-escalated, once their nervous system is regulating, they won't be able to tune it out. And these are the same people typically that don't like white noise after a while. They're actually supposed to be able to tune out this stimulation, but they can't. And so just tell them, that you're happy to turn it off. And once they have that feeling, it's already done its job. Okay, here's the second research. This is from Amano and Toichi in Japan, and this is from 2016. It's very new. Multi-channel near-infrared spectroscopy during memory recall with and without bilateral alternating stimulation. What they found was an increase in oxygenated hemoglobin in the right STS, a decrease in wide bilateral areas of the prefrontal cortex in the blast condition. So they said that this may help recall of more representative pleasant memories, create emotional regulation, and induce comfortable feelings and pleasant memories. So they're saying that it's warranted in some clinical situations to use this. Now, this wasn't to show that the memory enhancement retrieval, what it actually was showing is that this marker of stress, oxygenated hemoglobin, is actually changed. And so now we have this biomarker of stress that shows that using bilateral alternating stimulation in tactile form actually reduces a biomarker of stress. Touchpoints is actively researching this with cortisol right now with semi-pro athletes. So we will soon hopefully be able to have some other biometric markers of the stress reduction. We have EEG findings, we have clinical data, there's prior existing research, but we're really looking to add to this body of work so that you can know how to be savvy in applying this throughout more of your EMDR therapy. Okay. Moving on to phase 2 preparation. This is where you're establishing the relational trust and you're explaining EMDR theory and how it's done, what they can expect, and teaching the calming and relaxing techniques. In phase 2, teaching the calming and relaxing techniques, we rely on the research from Amano and Toichi that shows that when they're instilling a calm or safe place or doing these things, you're actually improving the biomarkers of stress in the brain, and we now have evidence for that. So this is evidence not only to use the blast in phase 1, but also in phase 2, where you're teaching the calming and relaxing techniques, and now you're introducing something, still staying within the 8-pronged approach, of course, but you're introducing something that is actually going to physiologically relax your patient more than just the techniques by themselves. When we move on to phase 3 in the assessment, and you're assessing each target in the controlled and standardized way, what's very, very interesting is that when they're rating their subjective units of disturbance, if you have used blast in phases 1 and 2, you need to reassess or assess the body sensation. And don't be in a state of disbelief if you've used blast in touch points and they tell you that their body sensation is 1 or 0 or 2. Okay, even if their cognition, even if their subjective unit of distress is still a little bit higher, they've actually worked through that because their physiological arousal was de-escalated with the use of blast. So if you get target ratings and then you use blast in phases 1, 2, and 3, you need to get them again before you process. And I would love to hear from you about how your excitement about how you're actually starting from lower numbers. Okay, and again, if you've got a person who's disturbed to a 7, their body sensation is a 6, and you used touch points in the first 3 phases, before you go on to phase 4, reassess that. Their SUD should be lower, and their body disturbance should be lower, and you have not even hit phase 4 yet. So to review, using the blast technology and touch points during phases 1, 2, and 3 is actually supported by research. If you do use touch points in the first 3 phases, you do not need to deviate at all from the 8-phase approach of EMDR as trained by the EMDR Institute. Adding the bilateral alternating stimulation in these phases is an enhancement to de-escalate the physiological arousal before phase 4 processing, and you don't need to deviate at all from those phases. I have additional research now for you that I'm going to review. Here's some more research that supports the use of bilateral alternating stimulation in the tactile form. And you can take this and think about it in terms of your patients who do not have DID and who you've appropriately screened, and also anyone in your life, including yourselves. Okay, we've got a study from Harper and Rasalakani, Calhorn, and Drozd from 2009 that has some QEEG studies that shows that the bilateral alternating stimulation in tactile form created significant depotentiation of the fear memory synapses in the amygdala. Now in this study, I want to be clear, they used eye movements and tactile stim. Okay, so that wasn't a complete differentiator. But when we look at the amygdala, we know that it has intrinsic connectivity to key brain structures that integrate sensory inputs, the fear response, and it can modulate or extinct fear. This is Ehrlich's and others' research in Neuron Review. Now, we found some new pathways to the adrenals, and this was quite exciting. Okay, this was from 2016, and this was Dumb, Leventhal, and Strick, and they found that the motor, cognitive, and affective areas of the cerebral cortex influence the adrenal medulla. Now, this blew my mind when I found this, because this actually was one of the bridges and the links that justifies peripheral nervous system stimulation. You stimulate the peripheral nervous system, and the somatosensory cortex processes this and actually directly can influence the adrenal medulla. And now when we look at this, we go back to the rat studies, somatosensory and auditory stimulation can activate parts of the amygdala. Only the somatosensory stimulation activated the ventrolateral amygdala. And the ventromedial amygdala didn't respond to either. And also there's an interesting finding that the lateral nucleus seemed to be essential in the auditory fear conditioning, which is sort of an aside. But basically, different stimulation affects different parts of the amygdala, and tactile stimulation affects a discrete part that auditory stimulation doesn't affect. Here's more evidence, at least in the animal models that we have, that Bilateral stimulation is not all created equal. Now, I could do a 3-hour talk on eye movements, and I will at some point, but for right now, please just take away to not substitute auditory bilateral stimulation for tactile bilateral stimulation. Okay. Question I often get is, can't we just tap ourselves? And the answer I say is, well, can you tickle yourselves? In the absence of external bilateral stimulators, tapping yourselves and crossing your body may do more than not touching your body at all to de-escalate arousal. However, it's substandard in terms of this. And some of you are concerned with the EMFs that are emitted from devices like touch points. We have tested these. It's very, very low, and you can use shielding cloth if you absolutely would like no emissions. But when things are rhythmic and when they're actually externally applied in terms of somatosensory stimulation, you want it to be externally applied. You want someone else to tickle you, in other words, instead of tickling yourself, and you will get a different effect because the cerebellum actually contributes to the somatosensory cortical activity during self-produced tactile stimulation. So in other words, your brain knows what's coming when you're doing it to yourself, and it has a different impact. This is the justification for using external stimulation, like in touch points, to do this. And why don't you want to tap your patients? You can tap your patients. However, your rhythm is not as precise as when you have the external applications such as touch points. That seems to have a different effect. And also the speed and overlap and all of these other things that are embedded in the waveforms, which is what took me so long to develop touch points, those are actually factors into how well the bilateral stimulation works. Also, I've heard of some therapists who don't alternate. They will tap on someone's leg, one leg, they'll alter it, and they're doing this unknowingly, thinking that they can produce the same effect. But there is actually a significant benefit from alternating the stimulation versus a simultaneous or continuous stimulation in both auditory and tactile forms. And if you'd like a reference to this, the Serin and others article in 2006 from Psychotherapy and Psychosomatics can help explain why that is. We have actual touchpoint user data of self-reported stress and self-reported body sensations, and we get an enormous reduction in just 30 seconds of this. And so when you add this to the pre-existing research, the EEG research that we have that I will actually present to you in another training if you'd like, and now actual user data from over 1,087 consumers, we have a well-rounded justification for using touch points during EMDR therapy. Thank you so much for spending your precious time with this today. I hope this was helpful. For more information, you can go to our website at ilovetouchpoints.com. Please email us with your feedback and your comments or any questions you might have. We would love to help out. And also stay tuned because our next development is going to be a very cool therapist app that's going to allow you to use touch points in all phases of EMDR therapy. Take care.